I'll be taking you through what are the actual differences in the pharmacokinetics and pharmacodynamics in children. And this will be followed by what are the common organisms and what antibiotics we should start with or begin with. And this will be also provided to you in a print form. I've shared my PPT so that the print can be taken or the PPT also can be shared for the So as we know that the antibiotics are the most frequently prescribed drugs. In any chart, if you see that, you will invariably see antibiotics. Even though it is more prescribed, even in pediatric population, there are only few drugs which are actually studied in the pediatric population. Most antimicrobials are given based on the studies which are done in adults. In children, most antimicrobials in children is given on the studies which are based in adults, and they have been more or less found safe. But we know that children are not small adults, and there are unique peculiarities of pharmacokinetics and pharmacodynamics. And because the dosages vary according to the age as well as according to the weight of the baby, they are more prone for errors, both during the dosage calculation as well as during dilution and administration as well. So what are the main issues in children and small babies? We know that the age and growth and development affect the pharmacokinetic processes, that is absorption, distribution, metabolism, and elimination. Dosages are frequently based on weight and or body surface area. And there are certain drugs which cause increased toxicity, like ceftriaxone and fluoroquinolones in small children. And there are differences in organ function and disease states. So we'll be just briefly seeing how it is affected. So the first thing is the absorption. So it depends on many factors like gastric acid secretion, the bile salt pool, gastric emptying time, motility, intestinal motility, surface area, bacterial colonization, and the presence and extent of the underlying disease. All these factors are reduced or not very well developed in newborns, and in children, according to age, this is variably affected. Like for example, when in the presence of decreased gastric acid secretion, the bioavailability of acid labile drugs like penicillins are more. However, the bioavailability of weakly acidic drugs will further reduce. Similarly, if we have a decreased size of bile salt pools, the bioavailability of lipophilic drugs will also decrease. Due to decreased or less gastric emptying time and intestinal motility in children, there will be more time required to reach the therapeutic drug concentration. And also this will hamper the absorption. Because of decreased surface area available for absorption, like for example, in the congenital atretic bowel or a surgically removed bowel, these can lead to specific absorptive defects. Coming to the volume of distribution, it varies with age. There are changes in total body water, a relative size or weight of the organ, and also it is dependent upon the plasma protein binding, membrane permeability, local blood flow, and other hemodynamic factors. So this is a chart just depicting the percentage of water in the body according to the age. So as we can see, most of the total body water, most of the premature, full term, less than 1 kilo babies have almost 60 to 80% of, lesser the age group, more is the total body water content. So this factor has to be taken into consideration because we know that we will require higher dose of water soluble antimicrobials at a younger age as compared to the older person. So further, there are three plasma proteins which are principally affecting the plasma protein binding of the drugs, namely the albumin, alpha-1 acid glycoprotein, and the lipoprotein. So these concentration are lower in infants, and it reaches the adult value by around 1 year of age. And the basic drugs are binding all the three drugs, while the neutral and acidic bind only to the albumin. This is important specifically in the newborn period because we know that there are some endogenous factors which compete for the protein binding site, and this can displace the free bilirubin levels in the newborn. For example, these drugs like ceftriaxone, cefoperazone, or sulfonamides, they will compete for the protein binding sites on these proteins, and therefore the percentage of free bilirubin will be more. So in this, the babies who are receiving these drugs, there can be problem of hyperbilirubinemia, and that could be detrimental to the baby. So the next process is the metabolism. It is slower in neonates than in older infants and children, And liver is the principal organ for the metabolism. There are two types of reaction for the biotransformation, the phase 1 oxidation reduction hydrolysis, which are the functional transformation, and followed by the elimination of the drug and excretion is mainly in the phase 2 by hydroxylation and conjugation with the sulfite and the glucuronide. And these requires enzymes, and enzymes mature at variable time of development. So the phase 1 activity is reduced in neonates, and it rapidly rises in the first 6 months of life, and then it exceeds the adult rates for first few years. Then again it slows down during the adolescence and reaches the adult rate at the late puberty. For the phase 2, sulfation is well developed in infants, but glucuronidation is underdeveloped. Excretion occurs primarily through the kidney and bile, and it again depends upon the plasma protein binding, the renal blood flow, the glomerular filtration rate, and the tubular secretion. All these factors are developing in the first 2 years of life. So it is very important to know what is the renal blood flow and the GFR in these age groups. So we know that the renal blood flow is low at birth, at around 12 ml per minute, and it reaches the adult level by 1 year of age. Similarly, for the GFR, it is around 2 to 4 ml per minute at the birth, and it increases to 8 to 20 by 2 to 3 days and reaches the adult level of 120 ml per minute by 3 to 5 months of the age. So the drug dosages of antimicrobials will be based on the age and the body weight of the patient, of the baby and the child. And it is a practical approach, but it's not the ideal. Ideally, we should measure the plasma drug concentration if whenever feasible, mainly because of maturational differences in what we have seen previously, the absorption, distribution, metabolism, and elimination. However, plasma drug concentration is not always feasible. So the practical approach is still with what we follow. So other considerations are you should look for the specific drug adverse effect, like tetracyclines are contraindicated in less than 10 years of age because of association with teeth abnormalities and bone problems. Then fluoroquinolones are associated with cartilage abnormalities in young animal models. There can be some decreased toxicity, like decreased anaphylactic reaction to penicillin and cholestatic jaundice by erythromycin, mainly because we know that the immune system is not very much matured, so they might not react, and the anaphylactic reactions may be less with penicillin in children. So the intramuscular sites for absorption for injection is, again, there is erratic absorption and unpredictable, especially in very small infants and neonates. This is mainly because of reduced muscle mass. There's a poor perfusion to various muscles and peripheral vasomotor instability and insufficient muscle contraction. So there can be, we cannot just rely on intramuscular injections even in children. Something about percutaneous absorption. Mostly we can, if we prescribe like topical antibacterial or antifungals, there can be increased absorption in neonates and young infants, because they have underdeveloped epidermal barrier, like the stratum corneum is very thin, and there is a lot of water content also. So all of these will can lead to increased systemic absorption of these drugs. And also there is increased ratio of body surface area to total body water, which is 3 times higher in neonates than adults. So if we, certain topical antibacterial is not to be used in very small babies. Even for procedures like we use betadine, if we use betadine in very small babies, you may not be dealing with neonates, but specifically in the neonates and premature babies, we usually do not use this, because even for surface cleaning, if we use this, there is an absorption and systemic absorption of these drugs. Then coming to the certain drug interaction. So we know that the cytochrome P450 enzymes and cytochrome 3A4 inhibitors, there can be various drug interactions with these enzymes and inhibitors. So the classical examples are the erythromycin and fluconazole. When given with CSAP, right, there can be toxic effects. The erythromycin and theophylline is not to be combined. Then chloramphenicol and phenytoin is not to be combined. A word about pharmacodynamics. Pharmacodynamics affects its effects, activity, and toxicity of drugs within the body is studied, is what is called as pharmacodynamics. So there are 2 types. I think this part has been covered probably in the first day: the time-dependent killing and the concentration-dependent killing. So it is the same for children as well. So we have this drugs like penicillin, cephalosporin, and vancomycin, which is mainly the time-dependent killing. The concentration dependent is aminoglycoside and fluoroquinolones. So this is just a chart to show what are the common organisms encountered in the pediatric age group and what is the first line antibiotic that we should start. All these are community acquired. We are not talking just about hospital acquired infection. These are all community acquired. So maybe you will get this, but just to mention, like for case of acute otitis media or tonsillitis, this is most commonly seen in OPD practice like pharyngitis and tonsillitis, where the common organism is group A streptococci H flu followed by and Neisseria meningitis. So again, the first line drug is penicillin V or amoxicillin or benzathine penicillin G. If there is an allergy, we can consider giving azithromycin or erythromycin. For urinary tract infection, E. coli, Klebsiella, and Proteus are the common. So we give ceftriaxone, third generation cephalosporin, and amiglycoside. So for the community acquired pneumonia, again, the organism varies depending upon your age group, but the most commonly penicillin and cephalosporins are the used. Again, for the meningitis, third generation cephalosporin or the penicillin G plus Genta, or the third generation cephalosporin in the older age group. So these are again the charts. So you will be getting this PPT for a ready reference if you encounter any pediatric patient in your population. Thank you.